Welcome to the deep dive. Our mission, as always, is to take complex source material and make it, well, really clear and usable. Today, we're diving into something fundamental in healthcare, the drugs used to treat anemia. We're pulling directly from Chapter 54 of Pharmacology and the nursing process.
That's right. And our aim is to break down, the mechanisms, the safety stuff you absolutely need to know, and the nursing care that goes with these drugs.
Yeah.
Sort of a practical guide for you.
Exactly, because when you look at these drugs, it kind of boils down to a couple of main ideas, right? It's not just one approach.
Not at all. You're either supplying the missing parts, think iron, B12, folic acid, or you're stimulating the factory, the bone marrow, telling it to work harder or better.
So we'll structure our dive around those ideas, those main drug classes.
Sounds good. But maybe first, a quick baseline, just so we're all on the same page about what we're fixing.
Good idea. Lay the groundwork.
Okay, so big picture. Hematopoiesis, that's just the fancy term for making all blood cells red white platelets, happens in the bone marrow. Then, more specifically, erythropoiesis is just about making red blood cells, or RBCs. And the main driver for that, a hormone called erythropoietin.
Ah, yeah, the kidney hormone.
Exactly, mostly made by the kidneys. It basically senses oxygen levels and signals the bone marrow when we need more oxygen carriers.
And the carrier itself, inside the red blood cell, is hemoglobin. Can you kind of paint a verbal picture of that molecule? It's pretty important.
Oh, absolutely central. So imagine a red blood cell, over a third of it is just hemoglobin. It's built from 4 protein chains called globin.
Okay.
And attached to those are 4 heme groups. Now, here's the key part. Sitting right in the center of each heme group is one single atom of iron.
Ah, so that's where the oxygen actually connects.
That's precisely it. The iron atom is the binding site. So you can see no iron, no oxygen transport, basically.
Which leads us straight into why deficiencies cause anemia. How do we usually group these anemias based on, what's going wrong?
We generally think about where the maturation process is failing. First up, you have what are called cytoplasmic maturation defects.
Okay.
This is your classic iron deficiency anemia, often from losing blood over time. You're missing the iron, so you can't make enough hemoglobin cytoplasm. The resulting cells look pale or hypochromic, and they're small, microcytic.
It makes sense. Less stuffing, smaller package. What's the second type?
That's the nuclear maturation defects, also called megaloblastic anemia. Here, the problem is in the cell's nucleus, specifically making DNA and proteins.
Right.
You're lacking the building blocks, usually vitamin B12 or folic acid. The bone marrow tries to make cells, but they get stuck, ending up really large, macrocytic, but they still have normal color, so normochromic.
And the textbook example there is pernicious anemia. Right?
Exactly. Pernicious anemia is specifically a B12 deficiency, but it's caused because the stomach stops making something called intrinsic factor.
Ah.
And without that factor, you just can't absorb B12 from your food, no matter how much you eat.
Okay, so we've got problems making the filling, problems making the nucleus. What's the third main category?
The third isn't about production, it's about destruction. Hemolytic anemias. Red blood cells are being destroyed too quickly.
Why would that happen?
Could be intrinsic issues with the cell itself, like in sickle cell disease. Or it could be extrinsic factors, maybe a drug reaction creating antibodies, or even physical damage, like from a mechanical heart valve chopping them up. The destroyed cells often look like little spheres, spherocytes.
Okay, that sets the stage. Let's dive into the solutions then. Starting with the drugs that stimulate the factory itself, the erythropoiesis stimulating drugs, ESAs.
Right. The main one here is epoetin alpha. You'll know it as Epogen or Procrit. It's essentially a lab-made version of that natural erythropoietin hormone.
And how does it work?
It directly stimulates the precursor cells, the progenitor cells, in the bone marrow. It tells them to mature into red blood cells much faster and get released into circulation quicker. Speeds the whole process up.
Seems straightforward, almost like a perfect fix. But there's a really big but here, isn't there? A major caveat.
Oh, absolutely critical. Epoetin alpha is basically useless if the patient doesn't have enough iron stores.
Right.
And, of course, if their bone marrow isn't capable of responding, you can rev the engine all you want. But if there's no iron to build the actual hemoglobin molecule for the new cells,
you get nothing.
Exactly. That's why almost all patients on ESAs also need iron supplements.
Okay. So main uses are anemia from chronic kidney disease, certain chemotherapies, some HIV treatments. But this is where things got complicated, right?
Right.
Tell us about that 2010 FDA advisory. That seems like a huge learning point.
It really was. A major safety issue emerged. The advisory highlighted that when doctors were pushing the doses, trying to get hemoglobin levels back to normal, or even just above 11 grams per deciliter, They saw a significant increase in really serious problems. Heart attacks, strokes, blood clots, and even deaths.
Wow.
So the thinking shifted completely. The goal isn't necessarily a normal hemoglobin anymore. It's more about reducing the need for blood transfusions and managing symptoms, but carefully.
So managing the levels, not maxing them out. What are the actual targets now? Like the hard numbers nurses need to watch.
For patients on dialysis, the target hemoglobin should generally not go above 11 GDL.
Okay.
For chronic kidney disease patients not on dialysis, it's a bit lower, usually aiming for around 10 GDL. And importantly, all these drugs carry a black box warning.
What for?
Increased risk of tumor growth in some cancer patients, and that risk of thrombosis blood clots. It's a serious consideration.
Definitely a constant risk-benefit calculation. Okay, quick practical point. How is it given?
It's an injection only, either IV or subcutaneous under the skin. The sub-Q route is actually absorbed slower, which often lets you use lower doses less frequently.
And handling.
Couple key things. Never mix it with any other drug solution.
Yeah.
And really important, do not shake the vial. Shaking can break down the protein, make it ineffective.
Got it. Don't shake. And how long until you see effects?
It takes a little while, usually about 7 to 10 days to start seeing the red cell count pick up.
Okay. So, since these ESAs absolutely depend on having enough iron, let's shift gears and dive into iron itself. The text calls it the main nutritional cause of anemia worldwide.
It really is. And iron does more than just hemoglobin. It's also key for myoglobin, that's the protein carrying oxygen in your muscles.
Right.
And it's involved in tons of enzyme systems for basic cell energy,
Yeah.
tissue respiration. So a deficiency shows up everywhere. Fatigue, sure, but also brittle nails, cracks at the corners of the mouth.
You can get it orally, like ferrous sulfate, that's the common one, right?
Yeah.
Or injectable forms. Let's talk oral iron first. The side effects seem like a big deal for patients.
They really are. The main complaints are all GI related. Nausea, stomach cramps, constipation is a big one.
Yeah.
Now, you can tell patients to take it with meals to lessen the upset, but you absolutely have to warn them that food, especially certain foods, can really decrease how much iron actually gets absorbed. It's a trade-off.
Okay, and what's the one side effect they definitely need to expect so they don't freak out?
The black tarry stools. You have to tell them up front, this is normal, it's expected. It just means the iron is passing through. It does not mean you're bleeding. Otherwise, panic ensues.
Right, crucial teaching point. Now let's talk safety, because there's a really sobering statistic in the chapter about iron.
Yeah, this one always gets me. Iron overdose is the single most common cause of poisoning deaths in young children in the U.S.
Wow, it's huge.
It is. Often because the pills look like candy.
Yeah.
Toxicity is incredibly serious. We're talking serum iron levels over 300 milli-GDL. It's a flat-out medical emergency needing urgent treatment, usually chelation therapy with a drug called deferoxamine to bind up the excess iron.
That just hammers home that these aren't just simple vitamins, they need respect. Okay, what about things that help or hinder absorption?
Good question. Vitamin C, ascorbic acid, actually helps iron absorption. So taking it with orange juice, good idea.
Okay.
But things like antacids, milk, calcium, they significantly decrease absorption. You need to tell patients to take their iron at least 2 hours apart from those. Don't take them together.
2 hours. Got it. And a couple of tips for taking the actual dose, especially the liquid form.
Yes. If it's liquid iron, they absolutely must sip it through a straw, a plastic straw.
Why is that?
To prevent it from staining their tooth enamel, it can cause permanent discoloration.
Good tip. And the other one.
After swallowing the pill or liquid, they need to stay sitting or standing upright for at least 30 minutes.
And that's to avoid
Esophageal irritation or erosion. Lying down right after can cause the pill to sit there and burn. Staying upright helps it move down quickly. Prevents a lot of discomfort.
Smart. Okay, shifting to the injectable iron. There seems to be a big safety difference between the older stuff and the newer versions.
Huge difference, yes. The older one, iron-dextrin, had a significant risk of severe allergic reactions, anaphylaxis. It wasn't common, maybe 0.3%, but serious enough that you had to give a small test dose first.
Right, the 25 milligram test dose and then wait an hour.
Exactly. Very time-consuming. The newer ones, like ferric gluconate or iron sucrose, have a much, much lower risk of anaphylaxis, so they don't need that test dose procedure.
That's a big improvement in workflow. Any specific watch out for iron sucrose?
Yes, with iron sucrose, you have to infuse it slowly. Pushing it too fast is known to cause hypotension, a sudden drop in blood pressure. So, slow and steady.
Okay, so we've covered stimulating the factory with ESAs and providing the key building block, iron. Let's move to the other main building block issue, the nuclear maturation defects. Folic acid comes first.
Right. Folic acid, another B vitamin, it's absolutely essential for making DNA and RNA.
Basic genetic blueprints.
Exactly, which is why it's critical for rapidly dividing cells, like those in the bone marrow making RBCs. But its most well-known use, really, is preventing neural tube defects in pregnancy.
Like spina bifida.
Correct. That's why it's recommended for anyone planning pregnancy to start taking it at least a month before conceiving and continue through the early stages.
Okay, now here comes probably the biggest caution flag in the whole chapter, maybe in all of hematology pharmacology. Why is it so incredibly dangerous to give folic acid before you know for sure the patient doesn't have a B12 deficiency, specifically pernicious anemia?
This is critical. Folic acid is great at fixing in the blood part of megaloblastic anemia. It helps the bone marrow make normal-looking red blood cells again, even if the underlying problem is actually a lack of B12.
So it hides the problem.
Precisely. It corrects the anemia, makes the blood count look better, masking the B12 deficiency. But here's the danger. The B12 deficiency itself isn't just about blood cells. It also causes severe, potentially irreversible neurological damage.
Oh, wow.
Yeah, nerve damage, numbness, tingling, coordination problems, even paralysis. If you fix the blood with folic acid but don't address the hidden B12 deficit, the neurological damage just keeps getting worse, unnoticed, until it might be too late.
So you absolutely have to rule out B12 deficiency first,
Yeah.
which brings us neatly to vitamin B12 itself, cyanocobalamin.
Right. Cyanocobalamin is the treatment for B12 deficiency, including pernicious anemia. And because pernicious anemia is caused by that lack of intrinsic factor needed for absorption in the gut.
You can't just give it orally, usually.
Exactly. For pernicious anemia, it's almost always given by injection, usually a deep intramuscular shot, to completely bypass the GI tract and guarantee it gets into the system.
Makes total sense. Okay, we've covered the drugs, the mechanisms, the big warnings. Let's pull it all together now. How does a nurse apply all this knowledge using the nursing process? Let's synthesize.
Okay, starting with assessment. It's not just about looking at the lab values, the HGB and HTT. You need to actually look at the patient.
What signs are you looking for?
Subtle things sometimes. Fatigue, obviously. Pallor, pale skin, pale conjunctiva. But also those specific signs like brittle, spoon-shaped nails or the cracks in the corners of the mouth, angular cheilitis. Baseline vital signs are key too, especially blood pressure before starting ESAs.
Right, you mentioned BP earlier. Why specifically focus on that with erythropoietin alpha?
Because as the drug works, it increases the number of red blood cells, which thickens the blood slightly. This can raise blood pressure, sometimes significantly.
Increasing risk for
Hypertension, stroke,
Yes.
heart attack, and those serious adverse events we talked about. So monitoring BP is crucial for tracking that risk. And of course, before giving that first ESA dose, you must confirm the patient has adequate iron stores. Otherwise, it's pointless.
Okay, assessment covered. Now, implementation, the doing part. Let's highlight the absolute must-do actions. For oral iron, what are the top 2 instructions?
Number 1, stay upright for 30 minutes after taking it. Prevents that esophageal burn.
Got it.
Number 2, avoid milk, calcium, and antacids for at least 2 hours around the dose time. Otherwise, you're just wasting the iron. Oh, and take it with plenty of fluid, 4 or 6 ounces, preferably water or orange juice.
Perfect. What about giving injections if for some reason iron dextrin IM is still used?
If it's IM iron dextrin, you must use the Z-track technique. Pull the skin sideways, inject deep, then release the skin as you pull the needle out.
And that's
Trap the medication deep in the muscle and prevent it from leaking back up into the subcutaneous tissue, which causes that permanent brown staining of the skin. It looks awful.
right. And because of that anaphylaxis risk with dextrin,
You absolutely need to have emergency resuscitation equipment right there at the bedside. Epinephrine, oxygen, suction, be prepared. Even with the newer 5E iron, you monitor closely during infusion for any reaction shock, sudden pallor, fast heart rate.
Okay. Finally, evaluation. How do we know if these treatments are actually working? And how soon?
It's not instant gratification, especially with the ESAs. You're looking at maybe 2, sometimes up to 6 weeks to see a good therapeutic response.
And what does that response look like beyond the lab numbers?
You look for what the patient tells you. Are they feeling less tired? Is their appetite better? Do they just feel generally better, have a better sense of well-being? And functionally, can they tolerate more activity than before? Those subjective improvements are key.
Along with watching the labs rise slowly and staying under those safety ceilings for HGB?
Exactly. Controlled improvement, not just lasting the numbers up. And always monitoring for any adverse effects, like those signs of iron toxicity or infusion reactions.
Great summary. So we've really unpacked the main classes,
Yeah.
the ESAs, like epoetin alpha stimulating production, the vital role and careful handling of iron, both oral and 5S, and folic acid, especially that critical warning about masking B12 deficiency.
Yeah, and what really strikes me is how this sophisticated, you know, biotech drug like epoetin alpha is completely dependent on having enough of a basic cheap mineral like iron.
Right. The high tech needs the low tech.
It totally does. It highlights how pharmacology often relies on basic physiology and nutrition being intact. The drug can't work in a vacuum.
That interdependence is fascinating. And here's maybe a final thought for you to chew on. We talked about iron being vital for hemoglobin in the blood, but you also mentioned myoglobin in the muscles. Think about that link. Basic nutrition, getting enough iron, isn't just about preventing anemia. It directly impacts muscle function, energy, maybe even athletic performance, and just your ability to get through the day. It really grounds pharmacology back into overall health and wellness. What stands out to you most about how these different pieces fit together?
It's that complexity, but also the fundamental nature of it all. Getting the basics right is paramount.
Well said. Thank you for diving deep into the sources with us today.
My pleasure.
Until next time, keep learning.